So earlier we discussed the challenge of taking pilots to scale and how our agenda is going to be a very solutions-oriented look at partnerships that have done just that, that are going to scale. Of course, another big challenge is reaching the last mile, getting access to those who currently don't have access. And we've heard a few examples of this so far, but this next panel is focused on partnerships that have worked to reach the last mile, and I'm thrilled to have a mix of leaders from different sectors, different geographies joining us. So please join me on stage, and I'll introduce you as you do. First here is Dr. Jay Iyer, Executive Director of the Access to Medicines Foundation. Hey, Jay, thanks for being here. We have Dr. Queen Dube. She's the co-principal investigator for NESS 360, which you'll hear a little bit about in a moment. We have Dr. Florence Guillaume, who's the Haiti Country Director for Global Health Supply Chains at Chemonics. And finally, we have Dr. Patrice Matchaba, who's the Group Head of Global Health at Novartis. So thank you all so much for joining us, our panel of doctors. I appreciate you being here. So I want to dive right in, and actually, I'm going to start with Dr. Queen Dube. For those who haven't noticed, I'm very pregnant. So as I was preparing for the sessions today, I watched a really compelling talk by Dr. Queen, and it really hit home for me as someone who's getting ready to deliver a baby. You talked about, through your work in Malawi, where you're a pediatrician working in Malawi at a hospital, in addition to your work with NESS 360, you've had babies die in your hands. And it's not because you didn't know how to save them, but you simply didn't have the tools to save them. So to me, that really paints a picture when we talk about lack of access. You have practitioners with the knowledge, but an inability to do anything about it. And I thought it was very powerful. Of course, NESS 360 is working to flip that dynamic, bring stakeholders together to reduce neonatal mortality in Africa. So can you just expand on what is this NESS 360 initiative, and what can we learn from this partnership when it comes to getting access to care at the last mile?
Thank you. So NESS 360 is actually an acronym. Nest, like an egg's nest, N standing for newborn, essential solutions and technologies. It's actually a consortium of about 13 institutions with one ultimate goal: to reduce preventable deaths for the African newborn. As we sit here in San Francisco today, every year in sub-Saharan Africa, we lose 1 million newborns. 80% of the deaths are preventable. Preventable with interventions, technologies that have been available in the United States for the past 50 years. Mm-hmm. And so what NEST is essentially doing is, why can't we make these technologies, interventions, available where it's needed most? And so we're working in Malawi, Tanzania, Kenya, and of course the giant of Africa, Nigeria, to move the needle in as far as newborn mortality is concerned in Africa. Moving from one device at a time to actually a suite of technologies. Because when a sick newborn comes to you as a clinician, they won't come with a label on their forehead that all I need is a shot of antibiotics. They might also be struggling to breathe. And as a clinician, you want a holistic approach. Mm-hmm. And that's what NEST is all about. Bringing in a suite of 17 technologies to the African newborn. And who knows, maybe beyond the African newborn, it will be the newborn in Nicaragua, the newborn in Asia. Let me stop there.
Just a quick follow-up question for you. We actually recently had a Devex story featuring you and a couple other speakers who will be here today at Prescription for Progress. And this story talks about distribution as this overlooked area, that there's a lot of focus on the tech and the financing, but not necessarily what are the channels through which these products are going to get to people. And I know distribution is a huge focus of NESS 360, so can you just talk about that?
I'll give you a very simple example. For me to get a phototherapy machine in Malawi, I'll probably pay 10 times what it will cost for somebody to get exactly the same in India. It is a pain to get a piece of technology to Africa, just because of the broken financial market in Africa. And a lot of investors look at it with an eye and they're like, well, the challenge is there, but I'm not going to do this at a loss. I need to survive. And so what we're trying to do is providing a platform where upcoming investors, really great innovators, can get their products where it is really needed. And so we're looking at different financing models, and that's why we have Nigeria, where, for example, we're working with a medical credit fund where they finance private institutions, medical facilities, and they have a 97% payback rate. Isn't that fantastic? Nigeria, the economy is quite interesting. And so we're partnering with organizations like those to make sure that these pieces of technologies are made available, but also thinking through how do you make the distribution work. So we're here in San Francisco, which is a joy for me because we're partnering with Third Stone Design that brings all these technologies together for us, and they ship them over to Africa at a fraction of a cost, making our governments being able to buy things that are affordable, rugged enough, and also sustainable in our environments.
And I believe there might be a representative from this design group here with us today,
Yes.
but definitely encourage others who are interested in learning more about this partnership to find you and learn more. In addition to your design partner here in the Bay Area, I know you have a lot of philanthropic funders
Yes.
who have come together in a coalition to support you. So I think NESS 360 is, and this is why you're here, and so glad to have you, a really interesting example to check out. I want to bring in Florence, if you don't mind. I actually heard you speak here in the Bay Area at an event on global health and was fascinated not only by your perspective on supply chains through your work with Chemonics, but of course you were the former Minister of Health in Haiti, so this is an important government perspective to bring to the agenda as well. And I'm curious if you can talk about when it comes to collaboration to get medicines and other essential health products to the last mile, given the perspective you have both as a former Minister of Health and now working in supply chains, what are your big messages or what advice do you have?
Thanks, Catherine, for the question. Good morning to everyone. I have to say that this is an honor for me to be here, and I'm sure that Chemonics is not going to be bad, or it's going to be mine if I get back a little bit to my shoes as Minister of Health after the earthquake, just to give you a flavor of what it means being Minister of Health.
Great.
I think this is a good opportunity that we have today, because in the past, being Minister of Health means being Minister of Healthcare. So now, being Minister of Health in the context of Global Fund is totally different. I can tell you that when I was Minister of Health, I had maybe an opportunity because I came from the International Development Organization, so which means that it has to be an opportunity for me at that time to learn a little bit why it cannot work between government and international partners. And at the end of the day, I understood that the word communication means something. When you are dealing with government, it's very stressful for the government. It's stressful for you who have a contract, who want to achieve your objectives, but it's stressful as well for the government to be able to show that they are producing results. And to produce results, they need you as resources to do so because they do not have enough resources. So, which means communication is really key when someone is going to a country, whatever country it is, to ensure that the government, at least your minister as homologue, understand what you are going to do and what is the added value. There's a step that is not taken often, for example, for a project that has a lot of money, is to ensure that you have an official launch of the project. Because ministers want visibility. This is the visibility, this is the action that you are going to conduct with them that can make them successful. So if you are bypassing this, let me tell you, you are going to have your results, but it's not going to be the country results. So I'm sure that my advice will be to take time when you come to a country, not to come to the minister just to have a social presentation, to say, I'm introduce you to this country director of this project that is going to work, and then that's it. You really need to sit down to technically present your project for the minister to give you the opportunity to show that you are doing something good for the country, and to give also to the minister part of responsibility of your success, of your failure. Because by having them showing this is a project in support to the country, you make them accountable for your success. So I think this is an important part, you know, that we cannot step, you cannot, you know, drop without doing if we want to move really toward this self-reliance journey that we are mentioning.
I think it's a great point. And just to preview something you'll all hear a little bit later, we're going to be hearing from Malaria No More. And I've been struck by, in preparation conversations with them ahead of this event, when they talk about the success of various projects they've worked on, it's always the success of Odisha, India. It's the success of, you know, the states and countries that they've partnered with. And so I think similarly, when we look at why some projects fail to scale, it's because the company or organization behind that intervention, they see it as their solution and not the country's solution, and that conversation is never had, right?
Exactly.
So to quickly follow up on that, now with your supply chain hat on, when it comes to reaching the last mile, why is that conversation with government so critical?
I think it has to be critical because most of the sites that we are working with are leading by the Ministry of Health. So you cannot go and penetrate to the sites without talking to the Ministry of Health. And even if I admit that it's an opportunity for me because I know well the system and I have friends, but I think it can serve for other partners that do not have, you know, friends inside of the NESS system in Haiti.
Yeah.
So my point of view is when I became country director, it was at the beginning of the project. Chemonics just had awarded the contract, you know, for the global health supply chain management, procurement and supply management. And what we have decided is to ensure that we can go to the minister at that time, the new minister, and to expose to the minister the well-being of the project and to link it with the strategic program of the Ministry of Health. Because there was at that time SNADI, things called SNADI, which is a unified supply management system to cover the national needs. So by putting this project aligned with the national strategy, it was easy. It was easy. And the minister just said, Florence, you can go, you know the system, go to the departmental directorate, go to the commune, and then go to the site. Which means it's like part of the Ministry of Health in all the ministry, the project. So from my point of view, even if Chemonics is working in 150 countries, you know, trying to strengthen the supply management system, but it's good to use this model to ensure that we can be successful in all the 150 countries.
Great.
Of course, now they are doing technical assistance in 60 countries, and they already have, from the 60 countries, 43 countries with a field office. So which means this is an opportunity to build on the field office to ensure that something will be reliant at the end of the project.
Great.
So this is the way we are acting, and we have each quarter meeting within the Ministry of Health, led by the Ministry of Health, with the national program leadership for HIV, TB, and malaria, and we are presenting our report, our data, and together we are taking the decision, which means that they feel they are part of the project. It's not our project, it's the ministry project with the support of Chemonics.
If we have time to return to this, I want to come back and hear how NESS 360 looks at government engagement as well. But I want to bring Patrice into this. So Patrice, I know you've spoken a lot about how emerging technologies like big data and artificial intelligence can democratize healthcare. And I think we can all kind of nod our heads and understand this, but what does this really look like? So can you just talk about a Novartis partnership, perhaps, that, again, looking at approach to partnership, how have you leveraged emerging technology in that way?
No, thank you. I mean, maybe I can give two examples, and congratulations to Rockefeller with the announcement of the community health workers. We just announced last month, actually, a partnership with Living Goods and Last Mile Health, supporting community health workers in 6 African countries, providing them with the tablet and technology platforms, not only ourselves, but with 4 other pharmaceutical companies, with money also matched by the Bill and Melinda Gates Foundation and the Audacious Project. So in total, $18 million last month to Living Goods and Last Mile Health. And the real power of it is that if you have these thousands of community health workers collecting data on patients on a daily basis, and we train them depending on the epidemiology in the country in terms of the disease prevalence, so 30 diseases with Raj and the team, is that you get real-time epidemiology. So you think about coronavirus now, you think about Ebola, you can pick up signals if you start using cloud computing and seeing abnormal fevers and pyrexia. So that's a practical example is going on, and we see this extending to South America and to Asia, and hopefully we can get to 100,000 community health workers and work with some of you guys there. But an example I want to give, and I want to echo what my co-panelists have said and the previous panelists, is that you guys actually helped us launch the Novartis Africa Ghana Sickle Cell Initiative at Davos last year.
That's right.
And I can't overemphasize this, the importance of getting government buy-in. And the criteria I've given my team as head of global health is that there must be an MOU signed either by the president or the prime minister, and in my case, Vess, who's the CEO. If there isn't that, we don't do it. And because of that, ever since we signed that MOU in Davos, the progress has been such. So we discovered that hydroxyurea saves lives. There's a New England Journal publication, should actually start the children at 1 year old to save them and save their organs if you want to preserve and prevent them from strokes. The most common cause of strokes in sub-Saharan Africa in children is sickle cell. So hydroxyurea is useful. But we discovered hydroxyurea is not even registered in a single African country for sickle cell. And the cost, patients had to fly to London from Nigeria and West Africa at $100 a month. So the power of partnerships, we then talked with the Ghanaian FDA, and they registered it in 3 months. 3 months. And then we said, this is a pediatric disease. There isn't a pediatric formulation. And we talked to our team in Sandoz, and we're working on a pediatric formulation, and again, we got approval from the Ghanaian FDA in 1 meeting, because the government is aligned with that. So we have approval, and simple things like, if you want to launch a huge public health program and introduce a lot of new technologies, and you have a lot of team members coming from different parts of the world, ensuring that you get multiple entry visas is important. Otherwise, you're going to DC all the time to get a visa, and you got 100 members. So we all got 5-year entry visas. And then we've partnered, we've made sure that, so we realized, okay, one of the problems is the hydroxyurea, we solved that. And then we said the diagnosis of newborn screening has to be integrated into the immunization schedule. But currently, only 4% of newborns are screened, and it's expensive. Now, we created what we call biomes, and we started off here in San Francisco. Vess has just opened another one in India. We're supposed to open up in Barcelona, but it was canceled because of coronavirus this week, yeah.
You mean the Mobile World Congress?
Yes. And the idea of the biomes is to take technology companies that have smart ideas. And what we can do, because we're present in 153 countries, is to provide scale and navigate with them through the regulators. So because of the biome here, we discovered there's a small company called Hemax that's making a diagnostic to say, is the gene mutation there in the newborn or not? The size is literally this size, as opposed to a large HPLC. And so we've now registered them with the Ghanaian government, and we're field testing that during the immunization clinics to make sure that every child who comes for immunization now is going to be tested for do they have sickle cell or not. So that's one, and it goes into the cloud, and the data goes to the government and so on. The second technology we introduced, we realized that there's a lot of counterfeits in Africa and in developing countries. The WHO says 170,000 deaths due to counterfeits. We've been talking with Jay about this. So what we did is that we took about 15 of our products, including hydroxyurea, and took the spectral library, put it into the cloud, and we've created a small gadget that we've partnered with another partner, which you have announced, we'll talk about them. So at the last point of mile, they can scan the tablet and see is it the correct API immediately, and that this product comes from Novartis. So that's a way of ensuring that there's no counterfeits. And we're working with another company now to ensure that the mother can scan the barcode of the medicine and can tie that with the spectral library and say, yes, it is the right medicine, so that we can assure the parents are getting the right medicine. So that's the second technology. The third one is that we realized that to get to the last mile, we have to be disruptive, and we partnered with Zipline. So we started the partnership. I myself went to see, because I didn't believe it. I went to Rwanda first to see them 3 years ago, and true to form, they are delivering blood and fresh frozen plasma and platelets using drones. So now we've partnered with them and the government and Zipline. The vice president is the patron of the partnership.
This is in Rwanda you've partnered with them?
Now in Ghana.
And also, I know
for
they're also in
sickle cell.
Ghana. Okay,
But
great.
the beauty is that they've now mapped all 1,200 last mile clinics. And we're going to collect the data with them, and the government will know exactly how many patients there are at each clinic. They've done about 700 deliveries. They've built 4 distribution centers. The target is 6 within the next 6 months, and they'll be able to do close to, I think, about 2,000 flights a day. So that is valuable, large-scale data where you can tie a specific drug with a barcode to a patient, to a last mile, and to a clinic. So there's a lot of technologies, but the importance of partnering with the government and the NGOs there is important. The other reason why we partnered with the government is to ensure that the supply chain is intact. One of the problems in developing countries, and the reason why patients end up paying more in developing countries than in Europe for medicines, is the markups that are put in the supply chain. There's an automatic 30% markup by the distributors. So this time we've ensured that it goes through the government to Zipline on the road, no markups, the government has agreed, no import tax to it, and we can control the quality. I can go on and on and on. But we hope sometime, just to show you that it has moved along, we hope at the World Health Assembly to make a big announcement. It's not Rockefeller, it's a big bank that has now said they're willing to join us and scale it for the rest of Africa, including the diagnostics and the medicines. And of course, Gates and NIH have just announced, because our vision for the next 10 years is that if we can collect all these children who are tested, we've created it's another startup starting from Boston called Dimaji, where all the children are now structured data set, is to prepare these children the next 10 years for gene therapy. So we'll have that database.
So we have some great examples of how Novartis is doing some of this work to reach the last mile, and it's the perfect opportunity to bring Jay in, because Jay, for those who are not familiar with the work of the Access to Medicines Foundation, you are working to change the way that pharmaceutical companies get their medicines to the poor. And while we've just heard from Patrice, who leads this global health work, there are a lot of challenges in what you're trying to do, right? These are private sector companies, and incentives aren't always aligned to get medicines to the people who need them most. I would love to hear from you if you can talk us through, again, back to this approach to partnership. Can you take us through a specific example of a company that, really its products were not saving lives in the way that they could be, and what you did to change that?
Yeah, sure. So let me highlight 2 major problems that some of the panelists here have also spoken about. There is today no pathway for affordable access for the patients who need them, especially when thinking about new innovations that are coming from the research and development pipeline. We are also at risk of older medicines that are still clinically useful becoming not economically viable, so companies are leaving particular fields and particular markets. So for several years, we have been evaluating the largest pharmaceutical companies and now moving in, so in looking at generics and some of the biotech companies, on what are they thinking, how are they setting up their partnerships early on, while the product is still in development, in order to guarantee that when a product is brought into the market, it reaches the patients that it needs, and within a few years, it can be ramped up in all the geographies where patients are. Realized that about 10 years ago, when I started this work on looking at this world, we used to have company leadership. Many people around the world used to also say, these innovations, they'll never reach low-income markets. They're not ready. The financing system is not available. And so I will never subject my innovation to that place because it will be dead and my reputation will be at stake. So one of the things that we've been trying to do is changing that way of thinking. What are the steps that you can bring forward, as Patrice already brought forward? How can you ensure that affordable access is guaranteed when a product is brought into the market? How are you thinking about affordability, working to finance your product entry? What speed that you need to take, and how do you need to set up the registration so that a product is registered in particular markets? And where are the patients? Where are the patients who are suffering the most? How are you going to reach them in a very short amount of time? And obviously the supply chain issue. Knowing that the last mile is going to be a problem, knowing that there are markups along the way, what are the systems that your business, along with the partners that you're working with, are bringing that forward? And over the years, we found many companies are kind of agreeing to this idea. Novartis is one of them, where they have declared that every product in their research and development pipeline, I have to directly look at Patrice when I say this, every product in the research and development pipeline will have a chance at access, and there is a special committee that looks at this. Yep. And more companies are starting to realize this is the case. In order to make that happen, we've had to bring investors. So investors tend to have a shorter-term view on the pharmaceutical industry, and a short-term return on investment, 6 months is kind of the norm. We've built now an army of investors, socially responsible investors. Some of the big banks like UBS, Schroders, pension funds have joined this cause and said, okay, let's engage with the pharmaceutical industry. We can choose who we engage with, even though we're, of course, responsible for working with different companies. We should engage with them so that we make sure that the ones who are serious about doing the right thing, serious about also expanding access to their particular products, are the ones we want to work with. And that's a growing army that is still struggling, let's be honest about it, to sort of bring that positive force and positive voice behind the companies. Because you know what? A lot of us don't have the opportunity to choose on which company we want to work with. Do we work with the leaders like GSK, Novartis, and Johnson & Johnson, who are serious about the issue, who know where the gaps are and are doing something to solve the problem as early as they can? Or do we want to work with, you can refer to our website of who I'm talking about, the companies who know where the gaps are and are working on small projects here and there that are not exactly solving the scale of the problem that we need. Because I think we need to recognize that 83% of the world's population right now live in low and middle income countries. So if our products are not reaching our patients, and we're not contributing to the health system innovations in order to make sure that the products are also going to be used in an appropriate way, then we're not doing anything about the problem.
So those companies that you're currently struggling to get on board, what are some of the strategies, just talking strategies and partnerships, what are some of the strategies, points of leverage you can use to try and change that?
There are not that many large enough influencers of the world. So we need to build either masses. So in the case of investors, we try to get, from 5 investors, we've got now to over 100 investors in place. Governments play an important role. Governments sometimes feel as if they're at the mercy of negotiating a particular product in or a particular service in from industry, or and this is wider than the pharma industry, of course. But providing them with the right tools to understand what are the potential opportunities that are there, who's doing more, who's doing less, in order for them to really leverage that, it's an important thing. And obviously, Bill Gates is really important. Bill Gates has a CEO roundtable that is co-chaired also by members of the pharmaceutical industry. And that's a fantastic platform where you can bring forward ideas of here's how you can reach scale. Here's how you can legitimately work on issues of affordability, work on issues of health system strengthening in order to make sure that this problem is solved. But when it comes down to companies that are notoriously not changing, sometimes my team and I are sometimes just constantly strategizing. What can you do? What can you do? Knowing that some of the companies obviously pay for the campaigns of political leaders, knowing that the largest banks in the world are still looking at financial returns over social returns. What can you do about that kind of situation is a big challenge. So we're trying to create that growing group of influencers who are daring enough, willing enough, able to take that risk in order to get that positive support.
And practically speaking, I just throw out one thing I've noticed. So earlier, Patrice mentioned this sickle cell initiative launching at Davos. And so the World Economic Forum meetings in Davos is actually where I first heard you speak, alongside Bill Gates on a session about some of these dynamics a couple years ago. And I would say just in terms of partnerships, it's convening people in one place. It's why we do an event like this. It's why there's an event like that. Say what you will about traveling to the Swiss Alps every January. But I do think I hear from people, we have meetings here with ministers of health, with CEOs, with head of global health NGOs that don't happen otherwise. And so it really is about getting people in the right room to negotiate partnerships, right? Which I know you do a lot of.
Yeah, it's getting people in the right room, reminding people not to sit back and be part of that golden cage where I don't have to do something to solve a particular problem.
Yep.
That constant reminder is where I think the platforms are important. And of course, these are perfect opportunities to network and make that first contact in order to in multiple ways, move the needle along. But it also is, I think very large platforms are also a place where announcemements can be made, commitments can be brought forward, and once you have a commitment, it's very, very difficult to go back. So creating enough platforms where commitments can be made can make a big difference, especially for the companies who are thinking, okay, what do I have to stand for the next 10 years?
Yeah.
Is there something I can promise out there?
And I think that's part of what we see our role at Devex as being too, is to then follow those commitments and say, hey, what's happened? So it's always good to follow up on those. We do have time for Q&A, and so I know some of you may be eager to ask questions of these panelists, especially since many of them have built on some of our earlier conversations. But first, I want to bring in, we're talking about the opportunities and challenges of partnering across sectors, including with the private sector. And I know we have someone here from Chevron who can actually speak to this very point. There you are. So Huma Abbasi is the general manager for health at Chevron, and I know that HIV/AIDS and other diseases actually threaten your workforce and the communities you work in. So there's a natural reason that Chevron is getting engaged in global health. What question would you have for a specific panelist or for the group?
Thank you. Thanks for the insightful dialogue. I was just sitting here enjoying, and some of the things were just so close to my heart. I do want to go back to Dr. Patrice. You mentioned just trying to resolve the simple things. So we have decades of experience in West Africa, Nigeria, Angola, where the population has been devastated by HIV/AIDS, malaria, tuberculosis. And while working on these programs, sometimes we realized that the solution was not just a very complex medication or access to healthcare, but providing transportation for the mothers who would actually be able to access the clinic and, for prenatal care, or, providing daycare for the kids so they can actually devote their time. Logistical support, technology. I just wanted to see, from your experience, looks like everyone is sitting here with decades of experience in providing access to care. If you can highlight some of the top challenges that you had faced, and how were you able to overcome those and provide that access to the general population?
So maybe just from my own experience, I mean, I think the previous panelists captured that. If you look at access to medicine as you rightly said, if you look at access to medicines at the last mile as just the medicine itself, you're missing the whole point. It's the whole ecosystem. And understanding you have to create different partnerships than we're used to. So for example, in South America, Chagas heart failure is a common problem throughout South America. And for us, the partnerships, it must include industrial consortiums, including car manufacturers, and whoever is a big employer in that consortium, besides the government and the doctors and the patients and the communities. And technology companies have become central to providing the bandwidth and the ability to collect data and to apply machine learning and analytics and know exactly where your patients are. So initially, our view, I think, as an industry was very simplistic. We thought that if you can just donate the medicine, that will solve the problem. We've been donating medicines for leprosy for the last 30 years, throughout the WHO. We're still getting 200,000 new cases of that biblical disease, including children. And then we realized that the donation in itself became a weakness because nobody created a global coalition in those communities to say how you eventually eliminate the leprosy. Because the medicines are there, we don't need new medicines. So one of the partnerships we just announced, and it's been going on for a year in Brazil, at Fiocruz in Rio, is with Microsoft. Because the problem is early diagnosis of the skin lesion. And if someone in the family has leprosy, then you have to give prophylactic treatment to the rest of the family, and it's a single dose which is available, right? So we've taken more than 1,000 patients' pictures of different skin lesions of different races. That's the beauty of doing it in Rio, so that in the end, people can take a picture and put it into the cloud, and you can take the picture at home, and it can tell you whether it's psoriasis, it's eczema, or is it leprosy. And if it's leprosy, then you must go to a local clinic and the community health worker, then you'll get the prophylaxis. So it's thinking disruptively with different partners and not excluding anybody in the partnership. This thing that we're not going to work with X in order to solve the problem is a limitation. We need to be totally disruptive. So I'm fully aligned with you there.
And I want to bring Dr. Queen into this, especially because since you told us about NESS 360, we've been talking a lot about partnering with government. And I think, speaking of challenges, we haven't heard yet how exactly is NESS 360 confronting that challenge, engaging the government in the work that you're doing.
So in Malawi, when you come to Malawi, NEST is the Ministry of Health program. Our minister was very, very clear that they don't want a project. They are tired of vertical approaches, one thing at a time. The first question they did ask was, how does this fit in within our strategy documents and our policy documents? And we had done our homework very well. We were able to mention exactly where the NEST program was going to sit in. As I speak today, we have 3 national program officers that are pushing the NEST program in Malawi. Our duty is to support government efforts. And people that have worked with governments for a long time, I have been in this journey for a decade now. There is always a conflict. You want to do things very fast. Government does things at a slower pace, but you are assured of sustainability. You will get there. The other arm, you are dealing with funders that have timelines, outputs, outcomes. By year 2, you must have done X, Y, Z. You started the journey with Minister X. A year down the line, there's Minister Y.
Yep.
You have to go back and knock on their door, re-explain. They have their own, agenda they are pushing. One of the things that I have learned is to leverage on a cadre that we haven't worked with a lot, and this is professional associations. It is a mighty battalion in as far as pushing the health agenda within Africa. I'm talking about pediatric associations, association of midwives, depending on which other field you want to work on. This is a mighty army. They are looked upon as neutral people, and also getting your champions in country is really paramount. And a lot more times, these champions will sit on national technical working groups. They're drafting the policy, they're drafting the strategy. You will be insane not to identify the national champion. Otherwise, you work for 3 years, fantastic results, write a paper, that's it. For me, success really is coming back 10 years down the line and seeing that which you have started still in the system and are impacting many, many, many lives. I just wanted to touch a little bit on the question that you raised on logistical support. We need to understand that we're working in a very diverse environment. I come from Malawi. 80% of our population is rural. So we're predominantly talking about smallholder farmers. These people are not employed by big companies. They have a little field. We're in the middle of the farming season in Malawi. If a mother comes to me with a small and sick newborn, they stay in my unit for 3 months. That's 3 months out of their field. That's a whole year's income. If I don't think about who is going to sort out their small field at home, so systems approach, again, thinking back to the community. We tend to think alongside our little silos. I work in a hospital, and so I'll put this child on CPAP, I'll sort out their breathing problem. I forget about the fact that this mother has a 2-year-old at home, a husband who is, spending all his time trying to figure out how do I get food for my family. If I keep this woman for 3 months without providing free lodging, decent bathing facilities for this woman, food for this woman, engaging the community on who looks after the other children for this woman, we are bound to fail. We're bound to fail. And that's why putting in systems within government, putting in systems, I emphasize, putting in systems within your government that will actually work to address these challenges is actually a big plus. We will always have donors. 70% of our health budget in Malawi is donor funded. We always have donors funding little things, but there's always a time. So when you work within your government system, that this is what we need to be doing, put in waiting shelters where women can sit, well, I want to say have fun, but find something for them to do for 3 months whilst they're with you, and look after their children back home, and think through, do I really need to keep this baby for 3 months? Or I keep for 1.5 months, send home, work with a community health worker, and make sure the whole system is vibrant. I can talk and talk and talk.
I'll say, and I wish we could. I know we're out of time, but so many ways to connect the dots between different things I'm hearing in the agenda today. What you just mentioned, later we're going to be talking about human-centered design and global health, like case in point, right, what you were just discussing there. I do wish we could continue. That's what our networking time is for later today, so please, if you didn't get a chance to ask a question, and I'm sorry we ran out of time, find these panelists throughout the day, but please join me in thanking them.